Welcome to week 3 of Advocacy, Ethics, and Public Policy. This is Tim Eccles. I'm going to use this presentation to update and expand a little bit on some of your readings, starting with a description of some basic types of health systems and how the ACA fits in among those. Moving then to more detail on the issue of risk selection, which I think is going to be important to our discussion around the repeal and replace efforts at the intensive. And then I'll wrap up with 3 particular advocacy issues as they relate to our class framework. I didn't get a chance last week to talk about how the Affordable Care Act fits within other approaches to health reform, including those that exist in other countries. The chart shows, first of all, a national health system and a single payer system, and I would note that these descriptions are fairly simplified for purposes of comparison. But what you notice here is that a national health system typified by Britain and then a single payer system typified by Canada are different mainly about the status of the providers. So both systems are financed by the government through taxes. Both systems involve the government as the major payer. But in Britain, the hospitals and physicians are largely either owned by or the physicians employed by the government, not all, but some, mostly. Whereas in Canada, you have mostly a private system still on the delivery side with private hospitals and physicians that are independent. Now, the U.S. exchanges and Germany fit more in this regulated multi-payer approach, where notice that the predominant financer is not the government, but employers, employees, and individuals, although the government is still involved to some extent. And then the payers are insurers. They are private rather than the government. And of course, the providers continue to be mostly private. And then you have market-based approaches. There's various types here, but the major goal of these approaches is to reduce regulation around competition among insurers in a way that is intended to bring down costs and improve quality over time. There's usually an emphasis on consumer sensitivity to costs, such as with medical savings accounts in these plans, in these proposals. Now notice that the market-based approach, the more pure market-based approach, they generally do not have universal coverage as one of their primary goals, whereas you get universal coverage with both the national health system and single payer, and potentially get it in the regulated multi-payer as well. Germany and Holland both do have universal coverage. Germany uses insurers, but they're non-profit. And then a goal of the ACA is to try to get as close as possible to universal coverage. Now, I find this chart instructive for 2 reasons. One is that as you move from left to right, you can kind of see the differences in the degree of government involvement in the system. And for example, the ACA exchanges still relying on private insurers as the main mechanism for coverage. The other thing is, if you look at the very bottom of the chart, you see that in the United States, we actually have all 4 models represented. The U.S. Veterans Administration system is like a national health system because the hospitals and physicians work for the government, such as in Britain, and then the single payer is Medicare is a very type of single payer system where you still have the private providers, but the government is the single payer in that program, and then with the U.S. exchanges under the regulated multi-payer. I'd like to go back to this slide from last week in order to expand more on the issue of risk selection. You read in the bar chapters about this concept of managed competition, and the Affordable Care Act is really a version of managed competition. This was a theory put forth by Alan Enthoven in the late 80s, early 90s, that the way to achieve lower costs and better quality in the individual insurance market is to use enough regulation so that insurers are competing with each other on cost and value rather than trying to avoid the sick. And by doing so, having individuals be sensitive enough to those costs, differences between the plans, that over time you can moderate the cost increases and enhance quality. This managed competition approach was attempted with the Clinton reform proposal, as you read, and then to some degree did come to fruition with the ACA. So a key component then to the ACA is this idea of ensuring or trying to disincentivize risk selection, that is the process used by insurers to try to avoid sick populations and attract healthier populations. And I've said before, this is not in any way to disparage the insurance companies, it's just the way our incentive system worked in the individual market before the ACA. Another term you'll see is adverse selection. Risk selection is more intentional. Adverse selection refers to situations where sicker people end up with some insurers and healthy people end up with others, not necessarily because of any intentional efforts, but because that's the way that they sort out. So what the ACA did, as we talked about last week, to achieve this is to move to community rating, where health status cannot affect the premium, except in the case of smokers. This is a significant change for the individual market, because whereas insurers started out with community rating in the 30s and 40s, especially Blue Cross Blue Shield, commercial insurers realized at that time that they could compete more effectively if they were able to, in effect, cherry pick healthier populations. And once they started doing that, then the Blues had to do the same thing. So we've had an experience-rated system for the last several decades until we moved to the community rating concept. We talked about guaranteed issue, meaning that people with pre-existing conditions or others cannot be denied coverage when they apply for it. The essential benefits I'll come back to in a moment. And then risk adjustment is important for reducing this risk selection problem. Recall that if insurers in the exchange end up with a sicker population, then they receive payments that are taken from the insurers that have a healthier population. And the notion here is to, again, reduce, if the insurers know that that adjustment will be made, you want to reduce their efforts to try to pre-select healthy versus sick to begin with. And then you have the individual mandate, which brings in healthy people to keep premiums affordable. It's a way of pooling risk and spreading costs, and of course it's also a way of avoiding a situation where the uninsured postpone getting their coverage because they know, because of the guaranteed issue provision, they know they can always get the coverage when they become sick. So what happens when you ban pre-existing condition exclusions but without a mandate? Well, first of all, the healthier are likely to say, I'm going to wait until I become sick before I get the coverage, whereas those that have conditions, of course, are likely to sign up. Once they do, you end up with a sicker pool, which drives up premiums generally. And then once you have those higher premiums, the next group of healthy people say, this is not worth it to me, and then they drop out. When they drop out, you end up then with a smaller pool with higher average costs once again for the sicker that remain. Premiums go up again, and then you end up with this vicious cycle, or what some call a death spiral, because eventually the survival of the insurance mechanism in the individual market becomes totally untenable. Now, you'll see at the bottom of the chart that there were efforts in the repeal and replace bills to try to replace the mandate with something else that would presumably avoid this problem, although there's a lot of controversy, and we'll talk about it at the intensive about how effective these mechanisms would have been. The House had a surcharge applied if somebody got insurance after not maintaining continuous coverage, and then the Senate version had a waiting period. Now, you've seen some of these slides before, but I want to spend a little more time on how the ACA and the exchanges are doing. We saw last week that 20 million people have gained coverage because of the Medicaid expansion and the exchanges under the ACA. But the future of enrollment is uncertain, especially in the exchanges. For a while, the exchanges had a tough go at getting stabilized, but they've actually reached a point now where there's considerable insurer participation, including at least one insurer across all counties in the U.S. And insurers are beginning to be able to predict the premiums more effectively and end up financially whole, whereas before some of that was difficult because they did not know what kind of populations they would be covering. There were some steep increases in premiums in the initial years. As it happens in 2019, there was actually a slight decrease on average in premiums, although that varied tremendously by geography. And in the last couple of years, there has been a modest decline in enrollment, a little under 3% in each of the last 2 years of loss of people who are covered in the exchange. And this is at least partly due to some of the things that the administration has put into place, and Congress as well, when they eliminated the individual mandate. We don't know exactly what caused what, but it does raise the question about what could have been if those actions had not taken place. A lot of experts believe that enrollment would have continued to increase over these years. And some experts also believe that the premiums could have come down even more than they have, and we'll talk a little more about that later. Now, at the bottom of this slide, of course, is a very important issue, which is the one that we hear about in the public arena a lot, is the high cost of the premiums that have risen fairly steeply since the ACA. But this does affect a relatively small group of people. It's a very important issue, but it is not an issue for the people in the exchange who get a subsidy. The 83% get a subsidy, and for those people, the formula is constructed in such a way that they are protected against these increases. But there are almost 7 million people who are in or potentially in the individual market, about 2% of the population that are affected by these increases, and so it does become a very important issue and one that Congress is very focused on, as we'll talk about in a moment. Now a little more about recent changes from the Trump administration and Congress. In 2017, as you know, there were multiple attempts by Congress to repeal and replace the entire law, but those efforts ultimately failed. But at the end of that year, Congress did repeal the individual mandate. They did so by reducing the tax penalty amount down to 0 rather than changing the mandate language in the law. This was because they had to do it that way due to a procedural issue. It remains to be seen just what impact this will have on the effectiveness of the law, because the mandate was only taken away during last year's enrollment and for this year. We'll talk more about that at the intensive. Cost-sharing reduction payments, this is a requirement in the ACA that insurers help financially those enrollees who are under 250% of poverty with their co-pays and deductibles. And then the federal government, in turn, would reimburse the insurance companies for these subsidies. The Trump administration removed the federal payments, but the insurance companies were still obligated by law to provide this help to people who are under 250% of poverty. They coped with that by increasing premiums in 2018, and then that situation continues today. There were efforts by the administration to make cutbacks in the promotion of the Affordable Care Act. As 2018, we saw significant reductions in funding for promotion of the law itself and education of people around the availability of subsidies. And also the time frame for enrollment was cut in half. The open enrollment period occurs in December. It is now half as long as it used to be. The Trump administration has also put into place 2 new rules that are likely to contribute to the risk selection problem we just talked about. Under the Affordable Care Act, short-term plans, a unique kind of plan, can exist for people for up to a 3-month period as a transition mechanism. The Trump administration extended this to a full year, which in effect makes short-term plans something that people can get on a permanent basis. The problem here is that many short-term plans are not subject to the same rules as the Affordable Care Act, which means they may end up being able to not cover people with pre-existing conditions. They can leave out many important services so that they're not as comprehensive as the Affordable Care Act plans. This leaves people, of course, who do sign up with the potential that they won't have their care covered depending on what their condition is, the potential for being excluded for a pre-existing condition. And then because certain services are not covered, it also puts hospitals and physicians in a difficult position where those services may not be reimbursed, which leads us back to the cost shift problem that we've talked about before. There's also a great concern that the short-term plans will tend to attract, because of these issues, healthier people, leaving behind the sicker people in the broader pool for the marketplaces. Similar issues for association plans. This is a rule whereby like-minded groups, civic groups, and others can join together in order to purchase plans on behalf of the whole group. But those two are not subject to the Affordable Care Act rules, so it continues to raise the possibility that healthier people will select into those association plans, leaving the sicker people back in the pool, and again contributing to those higher premiums. Now, that's not to say there's not advantages to these two rules, because of course they will make and have been making insurance plans more affordable, especially for that group we talked about earlier that are not getting the subsidies. But the concern, of course, is the long term, where we would continue to see an erosion of that pool and a erosion of healthy people in that pool as they are sort of pulled into these two other types of plans. These other two issues we will talk about at the virtual intensive, but want to end here with what we talked about last week with the challenge to the Affordable Care Act that is now in front of the Supreme Court. They will be making their decision next year. This will have a substantial and profound impact, of course, if the court does decide to strike down the entire law, not just because of the uninsured, but because of the multiple other elements that are in the Affordable Care Act and the various ways that it affects the entire population, not just those that are lacking insurance. Now, in using the course framework this week, I'd actually like to bring us to the third dimension, influencing policy with advocacy. And I'd like to use that dimension to introduce three contemporary issues that will affect your organizations and the Catholic Health Ministry. The first of the three issues is surprise medical bills. This has been in front of Congress for the past 2 years, although progress was interrupted by the coronavirus. We expect it'll be coming back, the issue will be coming back again later this year. The problem arose when patients were receiving unexpectedly high out-of-pocket bills because they were receiving care from providers that were out of network. Frequently, this was specialists within a hospital where the hospital was in network but the specialist was not, hence the surprise when the patients were receiving these bills. It also has been occurring around emergency services that are out of network. Congress has been considering a range of bills that fall into two basic parts. One is protecting the patients through some kind of limitation on the amount that they need to pay. The other part having to do with how the providers themselves would be paid, including physicians and hospitals. One argument has been that there should be provider rates that are set to some kind of benchmark. Another argument has been that instead there should be rate negotiation between the insurer and the providers backed by a dispute resolution process. Before the coronavirus hit, the Ways and Means Committee in the House did report out a bill that is supported by both AHA and CHA that has some good patient billing protections in it and does rely on the rate negotiation process rather than rate setting. CHA and AHA have been making the point that rate setting can create an inappropriate disincentive for insurers to develop adequate networks, especially in rural areas. The second issue is stabilizing and strengthening the Affordable Care Act. Again, before the coronavirus hit, Congress was considering and did consider in the last 2 years a series of fixes, as we talked about a little earlier, aimed at shoring up the Affordable Care Act and reversing some of the administration policies that have been put in place that appear to be contributing to a decline in enrollment. Some of these efforts were actually bipartisan. Back in 2018, there was a bipartisan bill that put in place a number of these issues that you see at the top of this slide. And then there was another package passed by the House last year, but it was known at the time that it was very unlikely to get through the Senate, and indeed it did not. I put this issue out here, though, because especially once we get through the election and through the virus issue, it is likely that this issue will come back and perhaps even be affected by the pandemic itself in terms of the plausibility of being able to pass something. Of course, it will also depend on what happens with the election. And then later next year, we will be getting a Supreme Court decision that could greatly change the landscape in terms of how the ACA is being treated, either that the ACA is upheld, where there still may be interest in doing these types of fixes, or a whole new world if the ACA is struck down next year. But we'll talk more about that at the intensive. The third issue is legislation around the coronavirus. One of the things that's going to be interesting about the issues you see on this slide is whether there's a long-lasting impact of some kind around these policy issues as well as our delivery system, something we'll talk about during our virtual time at the intensive. Now, the first category here, provider relief, the last package included substantial direct grants for hospitals and also relief around reimbursement. There's a program in Medicare that's been in place since 2010, a cost-saving program called sequestration that has been cutting hospitals and physicians 2% a year. That will be lifted for the year. Medicaid was scheduled for a cut at disproportionate share payments. That will be lifted for the year. And then there is a provision that private insurers need to cover out-of-pocket costs for coronavirus testing. Around regulatory easing, the legislation has included provisions to try to increase the workforce, to make sure that doctors and nurses can practice across state lines and in alternative settings, to allow providers to operate at the top of their license, which means that some that could not prescribe before can now prescribe, for example. And then there's been a moratorium on a whole series of quality and fraud reporting under the Medicare program to try to ease the administrative burden on hospitals. The second issue we've seen prominent in the news. There are some efforts in the legislation around supplies, staffing, and protective equipment, but this is also in the bailiwick of the administration as well as at the state level, still being worked out in real time now. The third issue, telehealth and virtual care, is interesting because of the lasting impact this may have. Medicare and Medicaid are now reimbursing on a much more liberal basis for telehealth services and also ensuring that patients don't have co-pays for that. And then some states are also requiring insurers to cover telehealth. This last issue, coverage and access, I've already mentioned that there have been provisions to limit out-of-pocket for virus diagnosis by private insurers and public insurers. What's not clear yet is whether some out-of-pocket costs might be limited for the actual care itself. Insurance coverage is an interesting one. These are two issues that are actually still alive on Capitol Hill now and being discussed, and we are going to use them as the focal point for our discussion assignment this week, as I'll describe in a moment. Marketplace open enrollment. There had been hope that the administration would create a special open enrollment period to allow people to sign up for individual coverage under the Affordable Care Act in the marketplaces. There are a lot of people, of course, losing their jobs that will no longer have the coverage they got through their jobs. Those people actually technically can sign up because they have a special situation. But people who worked for employers that did not have coverage before the virus hit cannot technically sign up. They'd have to wait till the open enrollment period that occurs starting in December. And yet, that group of people, those that are employed by organizations that do not offer coverage, is a big group out there right now. Those are the ones that tend to be in many of the service industries that are still operating even under the orders that are going on. So there was hope that the administration would go ahead and create this special enrollment period. They opted not to. The president has talked instead about using some of that grant money at the top of the chart in order to reimburse hospitals for care of the uninsured. But he did avoid the step of open enrollment, which has prompted Congress to discuss whether they should go ahead and pass legislation that would make that happen. The second point is the idea being discussed of creating incentives for those states that have not expanded Medicaid to do so. The original ACA, after the Supreme Court decision, did allow states to opt in or out of Medicaid expansion. They received for the first 3 years, if they did adopt the expansion, 100% financing from the federal government. The proposal here is that the 100% financing for 3 years be reinstated as a way to try to convince those remaining states to go ahead and enter into the Medicaid expansion program during this difficult time as a way of getting more people insured. So for this week's discussion assignment, I'd like you each to draft a letter to your member of Congress in support of the two policy options we just discussed. Special enrollment period for the ACA marketplace and incentives for those states that have not expanded Medicaid to do so. Write this letter as if you were writing on behalf of your facility or your system, and be sure to include references to our mission and examples of need from your own organizations, and then data to support your case. Now, you can use some flexibility here in terms of which congressperson you select for this, although I would like you to make it a specific member of Congress. In the case of Lisa, because her state has not expanded Medicaid, it may work well to do her facility's local member of Congress. For Patrice, because Kansas has not yet expanded, perhaps you could pick a member of Congress there, or if you feel more comfortable doing it for Denver, you can, although you'd be making the case for a next-door neighbor state. That's still fine. And then Chris, going either way on this. I noticed that Cancer Treatment Centers of America has a facility in Tulsa, Oklahoma that has not expanded coverage yet. If you'd like to focus there, or if you'd like to do some kind of system-wide approach for it, or even going back to Common Spirit, of course, has several states that don't have the expansion, if you'd just like to pick one of those. So flexibility in terms of who you pick for this, but let's make it an interesting exercise regarding the kinds of arguments you would make for these two issues. And I'll say more about it in the question section online, and we'll see you as we get into our discussions later. Thanks to all.